In this picture is this intermolar width is very less. But can you see this arch is very much constricted? Have you asked for any OSA? No? It's there? Okay. Since the arch is constricted, there is less space for restricted space for the tongue. So it leads to obstruction of the airway, the snoring. The patient was having typically this patient will have more darkness, here daytime tiredness. Have you asked it? Yes. Okay. So the plan is here, how many implants? 3. Okay. So whenever the arch is constricted, the number of implants required will become lesser. Because if the arch is more, the width is more, so you can place more number of implants. Even in full mouth, this applies the same. So this tooth we are retaining, right?
Yes.
No? This is left side. 2.8. This we are not removing. This is 1.7. 1.6. This we are retaining. No, we are removing. Okay. Because it is what many people using. Okay. So in the lower jaw?
Right side 2 implants.
This is the right side, right? Yes. So we are retaining this 2 premolar. Here 2 implants, huh?
Yes.
This side?
3637 4 implants. 3637 4 implants.
4 implants. This RCT.
If
After
it is
Confirm whether extraction or RCT. What we will do is we will remove. If it is good, we will go for a crown without doing RCT. Future need for RCT we can tell. Because so long time it has not given any trouble. So why to unnecessarily do RCT?
2 extraction. 2 extraction.
Okay, we'll see. So here if you see these 2 premolars, they are in contact, good contact. So if you give a new crowns, they should be in good contact. It's kind of very closed interlocked bite, right? So this we are removing?
Yes, sir.
Okay. If we remove, we may get some space, right? Here 2 implants, right? Okay. Accessory from. We can do some minimal amount of alveoplasty here to get 1 mm is enough. We can get some more prosthetic space. So mostly we will be saving these two, saving the canine and premolar. Then only it will be good for implants because they will take care of the occlusion. See, vocalingly it is very narrow, right? You can see even in first premolar area, you are seeing the canal. What is the name of the canal? What is the name of this canal? You can see here.
Accessory.
Incisive canal, which is a branch of infraocular nerve, right? So where is the metal from? It is here, right?
Mm.
In the second premolar, between first and second premolar. Okay. So the ridge is very thin, and crustally the ridge is not very good quality. You can see, no, lack of. Maybe recently extracted, right? But the canal is little far away, like we. Okay. So even 13 mm implant you can place, right? The length is good. Okay. So 360 degree you see, it is good only. So we are going to use second premolar, first molar and second molar. Mostly 3 implant is enough, but we have told 4. We will do it 7 also. The ridge is very thin. So you can place straight. Of course, smaller diameter implant. Okay. Here also you can place 12 or 13. Right? Definitely you can place. You can see the nutrient canal here. Can you see it? What it is called? You can see the nutrient canal, no? Can you see here in this window? And you can see here are the nutrient canals. Can you see? Okay. Now we're going forward. Oh, there is 8 here. We are not going to remove this 8. We are going to remove the root stump of 7. So actually 3 implant is ideal. Okay. Here you can go for lingual cortical engagement. Here we can place a 11.5, right? But slightly distal. This is more than enough. So tomorrow we can tell the patient only 3 implants. Because if you try to place 4, you will be eating the 8. Otherwise, you may compromise the inter-implant distance here. The more you go distally, the less prosthetic space. Access, everything. So, better to stay with 3 implants. So, right side. Now, understand why there is a rarefaction here. That is because of the previous metal ceramic bridge. It has got a buccal flange. Because of the pressure, this may be happening. This one. This. Okay, it extends. Can you see here? It is putting pressure here. And because of that also, there is crystal resorption. So the right side. Okay, the canal is very far away. You can go to 30 up to 13 mm. We can safely. Of course, smaller diameter. So all implants are 3.5 or 3.75, not 4 or above 4. Here the bone quality is very good. It's very cortical, right? So you should drill sufficiently, otherwise the implant will get stuck. Just straight drilling is enough. No need to plan for lingual cutting. You can place a 13 mm. See the bone, here only we have got less prosthetic space, right?
Yes.
So definitely we can do a small, yes, 1 mm alveoplasty will give good abutment length. So without hesitation we have to open the flap and do alveoplasty because we have got a lot of length here. The canal is also far away. Here we told
2.
2 implants, no? Actually here you can place a 3 implants because in upper right side we are planning for pterygoid. So we will stay with the plan. Okay. If we are not placing 1 implant here, we will place the extra here. Okay. So we need a good alveolar plastic burr. Here also 12 mm implant we can place. The more closer you are going to lingual, the lesser length it will become. The more away from the lingual area, the more. Okay. So it will be around 10 or 11, depending upon where you perfect. Here there is small root stump is there, right? Can you see the root stump is supplied by this? Okay. Now we will go for upper. So you can actually measure premolar width here in this cross section from the palatal cusp to palatal cusp tip, and you can check with the literature values. Okay, it will be around some millimeter, something. No, we have seen. Orthodontist use it for the need for expansion of palate. So almost it's like a full mouth rehabilitation. All quadrant we are choosing, right? So the right side is a little complicated, challenging because patient has got a deeply impacted supernumerary tooth and molar failed root canal with lesion and root stump 1-5 also with lesion. Okay, so you have to stay close to the mesial wall. So till the sinus floor or mesial floor, you have got enough length, but there is a lesion is there. If you are using compressive, you should cure it nicely, 100% perfect, or use a basal. You have to tilt it slightly mesially, and palatally of course, mesially to avoid the impacted supernumerary. Even if you touch and close to the thing, it's no problem, it will give extra stability. So I am just taking just some more mesial tilting. You are in good bone actually, right? So we are avoiding this view. If you see, we are avoiding this impacted premolar, and we have always checked the apex of the adjacent tooth. If the implant is close to the apex, that tooth will, blood supply will get compromised and it will become painful, or you can see, to the root apex, a little bit closer. So better we will. Okay. So we have to drill close to the impacted supernumerary to preserve the adjacent premolar, not too much tilting. And we are checking this is exactly in the interdental bone of 6, not the mesial root, because if you put in near the mesial root, it will become too close to the this is mesial root, right? So if you place in the mesial root, you will be entering the supernumerary and the implant also will be close. Okay, so what you have to do is, you have to go to the distal root area. Okay, this is the distal root area, right? So in the distal root you can place. If you see there is some radio opaque tips. Okay, so what is it? No, it may be GP, right? It may be the GP, I guess. No, it is a cusp tip. It is a cusp tip of impacted teeth. Okay, there is no GP. So what we are going to do, either we place a wider diameter of 5.5 basal or place a 3.6, getting engagement from this
Yes.
So 3.6, 14 or 17. Okay. So if you see in this view, apparently there is no bone at all. So if you use 5.5, you may not get good stability, right? So better use a 3.6 Of course, this is not a very ideal implant, but it will do. Okay. Now we are definitely going for pterygoid. There is no doubt about it, because the middle implant is not very ideal. We are definitely going for pterygoid. So sequence of implant we have to plan. Whenever you are planning for pterygoid sequence, if you place this implant first, then this implant second, you cannot drill this implant. You cannot place this implant. So always whenever pterygoid is there, first place the pterygoid. So since we are planning for pterygoid is very ideal, good one. Excellent. You can place a good pterygoid. 3.75 into 16 or 18, whatever it is. And this pterygoid implant may interfere with the implant placement of this one, but that is manageable. You can bend this, right? You can bend this and you can place this implant. So 3 implants on right side. That is the plan, no?
Yes.
So left side, how many implants? 3 without removing the 8, right? So here, so this is the second premolar, right? So second premolar, bone quality is good. The only thing is buccolingual, it is very thin. So up to 16, 3.75 into 16 will do. But if you see here, distal part is in the sinus. So a slight mesial tilt without compromising the root of X. Okay. Or what you can do is you put it straight. Okay. But short implant, yes. Just a short implant. But the thing is, the implant is very thin near the apex. So it shows it is inside the sinus, but in reality it won't enter the sinus, because the software it is a parallel implant. But what we are using is a tapered implant. So now we are finalizing the distal most implant, just anterior to the weight. So in the palatal socket we can place a either basal or compressive. We can place it. We have to cure it nicely. That is the thing. We need a short curate, small curate. 4.2 into 10 will be the fine option. If you tilt it slightly palatally, you can insert a longer. So now I should make sure the third implant is not very much close to other things. So of course they are close, right? Because we are tightly placing 3 implants. So in this kind of situation, what you have to do, select all the implants smaller diameter. Okay. So that inter-implant distance is maintained. So here 3.75 into 10. Stay close to the palatal wall. If you go like this, you can enter like this. Okay. So mesial implant is 3.75 into 16 or 13. Here 10 or long 0.5. Here 10 or long 0.5. Okay. And of course, the thing is, after extraction, we have to assess the need for any alveoplasty to gain prosthetic space, right? So whenever we are doing this kind of multiple quadrant, the challenge is, once you place this implant, any one quadrant, you cannot check the intraocclusal space for the other quadrants, because abutment will be heating. That is the main drawback. So for that, what is the one technique is, first we will finish the extraction alveoplasty, this side quadrant alto extraction alveoplasty, or finish the extraction of all the quadrants. Check the bite. Check the need for any alveoplasty or gingioplasty, do that. Then check again. Then start implant all over again. Instead of finishing one quadrant, jumping to other quadrant, you have to finish the extraction, the alveoplasty in all the quadrants, then start the implant. That is the better option. Otherwise, we cannot able to assess the prosthetic space and we may do some mistake. That's it.